Um, so hello, everyone. We are very happy to kick off our 2023 IHOP webinar series for the Clinical Immunology Special Interest Group. This is the first of our series, and we are delighted now to have two speakers, Dr. Melanie Degliuomino, who received her pediatric hem-onc training at the Memorial Sloan Kettering Weill Cornell Medicine Fellowship. She was actually one of my fellows, so I'm very, very happy to have her here. And she's currently a practicing faculty and assistant professor of pediatrics at the Hackensack University Medical Center, New Jersey. After Melanie's presentation of her case, we have the pleasure of having Dr. Jack Bleesing from Cincinnati Children's. He is a professor of pediatrics at the Cincinnati Children's Hospital, and he received his MD PhD at the University of Leiden in the Netherlands, and they did his pediatric and allergy immunology training in the US. He's currently the co-director of the Diagnostic Immunology Lab at Cincinnati Children's and Associate Director of Immunodeficiency and the Histocytosis Program. So he's a world-renowned expert in primary immunodeficiency disorders and immune reconstitution following bone marrow transplant, as well as in diagnostic immunology. And so here are the introductions, and Melanie, you can start with your presentation and unmute yourself. Thank you.
Great. Thank you, Dr. Kaicker. So I'm going to be presenting an interesting case of a patient that I had earlier this year. So I'm just going to advance. Perfect. So this was a 4-week-old female infant who presented to our emergency department with a chief complaint of fever and emesis acutely just for 1 day. For some birth history, she was an ex full term. She was born vaginally to a mother, a first pregnancy. And to note, she was born from consanguineous parents. They were first cousins of Yemen ethnicity. From report, she had a newborn screen that was negative and a hearing screen that was also normal. The infant, reportedly from mom, had been fed a combination of breast milk and formula. She's been growing well, developing adequately for age. No real red flags within the first month of life. For her initial labs in the emergency room, she was noted to have a leukocytosis of 30.4, anemia to a hemoglobin of 5.7. Her platelets were mildly low at 132. And notably for the differential, she had a lymphocytosis, an absolute ALC of 21.7 with 13% atypical lymphocytes. Some additional blood work showed that her renal and liver function was adequate at this time. She did have an elevated LDH to 692, and her ferritin was markedly elevated at around 2200. Her uric acid was unremarkable. She did have a reticulocyte count that was elevated to 5.9, but in the setting of her hemoglobin of 5.7. Her direct Coombs was negative, and she did have an elevated ESR of about 119 with a mildly elevated procal as well. For her physical exam, she was sleeping comfortably in her mother's arms. On exam after awakening, her oral pharynx was clear. She was noted to have very firm lymphadenopathy palpated in her axilla region. Her heart exam was reassuring, chest exam was clear. Her abdominal exam, she was noted to have a very profound protuberant abdomen that was firm. Was difficult at that time to palpate hepatosplenomegaly, just given she was so had such a firm belly, but to the degree of her hepatosplenomegaly, which I'll get to on imaging. And then otherwise, pretty unremarkable. She had normal infant reflexes, no rashes, petechiae, and had notable pallor in the setting of her severe anemia. For some just additional infectious workup that was done in the emergency room, she was noted to have a urinary tract infection, just of 1,000 CFUs of Serratia, which is an unusual organism. Her blood culture was drawn. A lumbar puncture was not done at that time, and then her viral panel was noted. She was tested positive for rhinoenterovirus. For her initial imaging, this is imaging from her. We initially did an abdominal ultrasound, which showed she had a mildly enlarged liver, moderately enlarged spleen. She had hypoechoic solid nodules surrounding the aorta and IVC, which were noted to be most suggestive of lymph nodes. And then she had lymph nodes in her iliac and inguinal area as well. And then a CT chest, abdomen, pelvis was done following that showed the very large axillary lymph nodes measuring up to 3.5 centimeters. And then she had diffuse lymphadenopathy really throughout her abdomen and pelvis, as well as an enlarged liver and spleen, measuring up to about 9.5 centimeters. So initially for our differential at this time, while the patient kind of was admitted into the hospital at this age, so we have a neonate, a 4-week-old, who came in with fever and emesis for really one day, but has this profound lymphadenopathy, pancytopenia, leukocytosis with anemia and thrombocytopenia, and elevated ferritin. So, I think in this kind of setting, also in the setting of having consanguineous parents, we were thinking of somewhat potentially unusual lymphoproliferative immune dysregulation. Infectious was one of the biggest differentials at that time as well, just given we weren't really sure in regards to her exposures. And then malignancy as well. Could this be a presentation of infant leukemia, a neuroblastoma, an unusual lymphoma, just given the lymphoproliferative or the lymphadenopathy? So the differential was very broad. So kind of over the course of days to weeks, we continued our workup, and she had an infectious workup done that was along with our ID colleagues, and was very negative. We did PCRs that showed that she was negative for a lot of viral etiologies, bacterial etiologies. And to kind of work up for malignancy, so she had a leukocytosis at initial presentation. So we initially ran flow cytometry on her peripheral blood, which was negative at that time for blast population. We later ended up doing a bone marrow aspirate on the patient, not initially, but just to include it in the malignancy section as well. There were no aberrant blast populations within her bone marrow either, but she was noted to have notable lymphocytosis predominantly. So then kind of continuing on our path of diagnosis, we started to look at her immune system and some specific biomarkers, her immune globulins, which are all elevated for age, for her IgM, IgA, and IgG. We, in the setting of her being an infant with potential, with consanguineous parents in the lymphoproliferative process, we were thinking, could this be a presentation of primary HLH or potentially secondary HLH to some type of immune dysregulation? So we sent some of the biomarkers that could be consistent with HLH. The soluble IL-2 receptor was markedly elevated at 29,000. Her ferritin, as I mentioned, too, is very elevated. To note, her CXCL9 was not elevated. Her IL-18 was very elevated at 4,500. Triglycerides didn't really kind of meet that criteria for HLH, neither did the coags or fibrinogen. So kind of in looking at the criteria for diagnostic HLH, she did in fact meet 5 of the 8 diagnostic criteria with fever, splenomegaly, cytopenias, ferritin, and elevated soluble IL-2. We did end up sending, which didn't come back right away, obviously, since it was a genetic panel, but we sent a familial HLH on her as well. And all of those genes came back negative later on. But just to kind of note the clinical state of the patient, despite her having these lab findings and physical exam findings, she was noted to be remarkably stable. We really had the luxury of time in not treating her, and we hadn't given her any type of steroids or non-steroid medication at this time. And her labs kind of remained stable throughout her hospital course in regards to like her cytopenias and inflammatory markers. She never decompensated, never required supplemental oxygen or any other type of support in that sense. So not really fitting the picture potentially of like a primary HLH either, or secondary due to an immune dysregulation. So then to continue our workup, we decided to obtain a sample of a lymph node. So she had an axillary excisional biopsy performed. This is the panel on the left is actually not from her flow. The one on the right is from her flow. But kind of to give you the findings, so she had a high population of double negative CD4, CD8 with a T cell receptor alpha beta positive T cells. These are kind of hallmark for in the setting of lymphoproliferative process of an ALPS type of picture, some type of autoimmune picture. This type of population can be normal in individuals if it's kind of less than 2%. Hers originally was definitely greater than 30%. Here it looks like it was 54 based on this tissue, this flow. So she had a very elevated population within her lymph node. And this is actually not her histopathology. I'll explain why, but this is kind of the classic histology that you would see with ALPS. What you typically see is follicular hyperplasia and paracortical expansion with small proliferative lymphocytes, which are kind of highlighted in these photos. Usually the architecture is preserved, which kind of differentiates it from a lymphoma. Unfortunately, in our patient, her lymph node was actually, the architecture was not preserved, which made it a little bit more complicated, which we think could have been due to the processing of the lymph node. So we actually got second opinion from the NIH in looking at our pathology as well, which is why we ended up doing bone marrow on her as well, just to make sure after we got that kind of not conclusive lymph node pathology or histopathology. So then additional workup that we did for her, so looking at some biomarkers that could be consistent with ALPS or autoimmune lymphoproliferative syndrome. So her IL-10 was elevated, and the normal ranges are in parentheses next to it. So a cytokine IL-10, her vitamin B12 was elevated, which can be elevated in a lot of, in some lymphoproliferative processes. We ended up doing a soluble fast ligand, which was markedly elevated in conjunction with the CD95 expression, which can be a marker on T lymphocytes. Her expression was actually 0, which was concerning for not having the ability for to kind of proceed with apoptosis. And then her apoptotic resistance assay was very low as well. Cincinnati Children's, and I know Dr. Bleesing will go into this more, but Cincinnati Children's has an ALPS criteria that you can send for flow cytometry. So in kind of looking at the different criteria that encompass the risk of or the likelihood of having ALPS, she made definitely 3 out of 4. Her level for the T cell receptor alpha beta double negative T cells was actually 26.8% from her blood. And then her T cell receptor alpha beta double negative T cells B220 was 97%, so greater than 60. And then the CD3, CD25 to HLA DR ratio was less than 1%. Hers was actually 0.5%. Her memory B cell population was actually 16%, so it was very borderline, but wasn't given that credit for the 4th. So kind of encompassing all of this, she very much kind of looks like, based on biomarkers and her physical exam, that she kind of meets the diagnosis of ALPS. But we ended up doing genetic testing for her as well. She had whole exome sequencing done. It did show that she had a FAS mutation. These are autosomal dominant mutations, and she actually was homozygous, so acquired a mutation from both her mother and her father, and her mutation resulted in a premature protein termination, or like a fast truncating mutation, which explains why her CD95 was 0 and her fast ligand was.
What time is it? You have something now?
No, sorry.
Can you please mute yourself?
Okay, so in management for our case for this patient, so our hope was to kind of preserve and to try to decide on steroid-sparing agents for her, just given her young age and the thought that she's going to need to be on it for somewhat long term. So we ended up starting her on sirolimus. The dose that we obtained was from some neonatal literature, but you can kind of see based on these graphs from EPIC that once we kind of started it, which was really, we started it in the beginning of September. Her counts were kind of the lowest at that time. And then she's been on this medication for a year now. And her, in keeping kind of therapeutic trough between 5 to 15, her cytopenias have improved. They've resolved. They're normal for age at this time. Clinically, she's growing, she's developing. I'll tell you other surveillance that I'm doing for her as well. So why did we choose sirolimus for one? So most ALPS patients were, at least through literature, kind of have a good response to sirolimus. And not only does it kind of target the cytopenias, but it also helps with the lymphoproliferation in lymphoid organs. So that's kind of why we decided to use it in her, just given her profound lymphadenopathy and hepatosplenomegaly. This is a study that was done. It's a retrospective study on patients with ALPS, on pediatric patients with ALPS. And the median age at onset for this population was actually 4 years of age, but they were started on sirolimus with a similar trough, and they all had treatment responses within kind of 6 to 9 months, and they achieved a CR, complete remission, which they defined as kind of achieving normal platelet counts, having absent splenomegaly, lymphadenopathy, and the median treatment time for these patients was about 3 years, but they had significant improvement in their biomarkers, which you can see from these graphs over a kind of that 6-month period of time, where their double negative T cell population decreased, their inflammatory markers, the soluble fast ligand decreased. So all kind of a positive biomarker response and clinical response based on this. So that's why we kind of chose that. And this is just another study of utilizing sirolimus in ALPS patients. This was a prospective multi-center study that looked at pediatric through adult age with similar dosing, and the 11 out of 12 patients achieved a complete response within 3 months. And the length of treatment in some of these patients was actually up to 8 years. So it was a combination of ALPS and non-ALPS patients, but kind of similar to give us some evidence that sirolimus would be good for her. Surveillance for our patients. So we've been monitoring her right now clinically. We've been seeing her, monthly to every couple months. I've been doing some abdominal ultrasounds on her. I've been doing them basically every 6 months so far. So we have a few under our belt, and her organomegaly and lymphadenopathy has improved. Her lab monitoring as well, as I mentioned, she no longer has any cytopenias. So I think from that standpoint, her labs are not getting worse. And then we are periodically sending the flow cytometry panel for ALPS to Cincinnati Children's, just to kind of monitor her percentage of the double negative T cells as well, which is also decreased. So I know Dr. Bleesing will go into this. I don't know if I can kind of briefly just talk about a couple of slides, Dr. Bleesing, or if you wanted to kind of comment on the patient too, whatever works moving forward, I can mute.
So I think it's might be good to just go back to the patient for a moment, because in the workup, because there are some really interesting aspects of this particular workup. So maybe you can go back to the slide showing your ALPS. So yes. So as you mentioned, I often get asked, if you just look at CD95 or fast expression, is that abnormal in fast patients? And then usually if this is a typical ALPS patient with an autosomal dominant disorder, there's normal CD95 expression on the surface, because you have to remember it's a trimer, and in most cases the trimer is formed as long as there is some protein translation from the abnormal gene product. But if you have a homozygous defect in this case, you could argue that no fast protein is made whatsoever. And so that's actually the first time we could actually test this theory that I have, that if you have homozygous defect or compound heterozygous defect, you probably don't have any CD95 expression whatsoever. And that is probably also the reason why the apoptotic assay was so abnormal. And we can see very abnormal, fast-mediated apoptosis even in just the typical autosomal dominant fashion where you have a normal allele and an abnormal allele. And then the other thing that is really interesting about this is that in typical ALPS patients, you score a 4 out of 4. If you look at the memory B cell part, considering that this is a very young patient, and this is an age-dependent marker, that struck me as really interesting that at her young age, she already had about 16% memory B cells. And the pathology wasn't completely characteristic of ALP as well, because the one that you showed, you can perhaps go back to the slide showing the pathology. You see these very typical and characteristic big follicles, right? You see 2 of those on the right upper quadrant, and that's called progressive transformation of germinal center. So that is sort of classic for ALPS. And perhaps this is a really young patient, or perhaps there was something else going on in this patient to explain this, right? You have 2 infections, which is not really typical for any neonate, but certainly not for ALPS as well. So I think that's, and then the question is if the cytopenias are truly autoimmune mediated. I mean, there's profound anemia, but you really want to know if this is due to an antibody against the red cell. And in this young patient, it could potentially be maternally derived, but let's just assume that this would be Coombs positive hemolytic anemia. That's important when we go to your last slide and sort of asking the questions, what do we need to think about? And then the family history, I think, is important because both parents are carriers of this defect, and presumably they are normal. There might be other relatives in this family who have the same FAS mutation. And so it is really interesting to look at this. And I'll come back to this in a second, why it is so important to do family studies in cases like this. Now, if you go to the slide showing a little bit about ALPS, we know that this is, in most cases, is an autosomal dominant disorder. And that is due to the fact that FAS, as you can see in this figure, is trimerized. And if you have a mutation in one of the gene, you can make 8 configurations of a trimer. In 7 out of these 8, there would be at least 1 abnormal FAS protein as part of it. And that probably explains the autosomal dominant nature of this disease for intracellular mutations and for certain extracellular mutations that do not involve a region of the FAS protein, which is called the pre-ligand assembly domain. So FAS is assembled in a trimer before it engages its ligand FAS ligand. And there is a specific region in the FAS protein that mediates that. So if you have a mutation in that, what's called the PLAT domain, you would not form any trimers, and then you probably end up with what we think is a haploinsufficiency mechanism. And those patients can have a relatively preserved FAS-mediated apoptosis, certainly when we measure that in our lab. And if it's a typical death domain mutation in exon 9, the FAS-mediated apoptosis is severely affected. So that's important to remember. The patients can have similarly severe disease. So the degree of FAS-mediated apoptosis is not necessarily a prediction of how bad ALPS is at presentation or might be in the future. And just looking at the degree of FAS-mediated apoptosis defect, I can really make no prediction of what the patient would look like. I think it's the biomarkers that are really helpful in that. And I have to say that this was the highest FAS ligand level that we have measured thus far in any patient. And the IL-10 is very, very high as well. So I think it all fits nicely. And then I think it's important that there are also normal biomarkers, right? The CXCL9 was completely normal. And that tells you that this is really not a gamma interferon-driven process of CD8 cells, and makes it easy to distinguish this from HOH. And when you're dealing with a patient with, when everything is going on, it can be difficult to sort out these different scenarios. So apoptosis is fully penetrant in families. Any individual in the family who has the mutation will have defective fast-mediated apoptosis, but clinical penetrance is not 100%. So you can have something else needs to be present in order for a patient or a family member to develop ALPS. And that is why we have designed the ALPS panel the way it is, because in a relative who has the fast-mediated apoptosis and the germline defect but doesn't have ALPS, the first 1 or 2 points of the ALPS panel may be abnormal, but item number 3 and number 4 may be completely abnormal. So it helps me in sort of sorting out in families whether they actually are at risk or have ALPS, or if something goes on. And then there are lots of, for every 10 patients that are referred to me for ALPS, 9 will have something else. Often I don't know what they have, but the ALPS panel is very helpful in sort of sorting out in what kind of category the patient fits in, and that is helpful in designing sort of a therapeutic plan. So that's about biomarkers, family history, documenting that this is a Coombs positive hemolytic anemia, and then I was struck by what you said, that you have the luxury of time, and I think that's really typical for ALPS, is that you often don't have to run to get the patient started on therapy. Sometimes you just need to treat with a little bit of steroids just to regain a little bit of control in the system, but you often have time to sort things out. And as we know with HLH, there is no such thing as luxury of time. You typically have to get started on treatment, and usually on Friday at 5 o'clock in the afternoon, because that's when we get the emails and the phone calls. So if you can go to, I think, the last slide. So this is, go back to that, because that's another interesting thing is, and as you measure, as you mentioned, there is a male to female discrepancy, not just in the lymphoma, but when you look at the 2 big cohort studies that have been published, one by the NIH group and the other one by the Paris group, is that when you look at severe cytopenias, autoimmune cytopenias, we see a similar male to female ratio of about 3.5 to 1. And I see that in my own cohort of patients, and I follow about 30 patients, and 20 of them are male. And I have probably a selection bias in the patients that come and see me in clinic. So there are probably many more patients out there that I don't see, and that probably has more females than males. So that's an unexplained observation. We don't know why that is. We do know that the increased risk of lymphoma is likely lifelong. It can be a first manifestation of ALPS, and we have actually found this in grandparents of FAST patients. If you go to the next slide. So this is another interesting slide, because it is, I think it is kind of a shame that there are and I can only blame myself in that we have not published our cases as well. But there are more cases of transplanted ALPS patients. But by and large, this is not something that we have done for ALPS patients. And often when I mention this within the hematology community, folks are really defensive. No, you should never transplant this. And I kind of agree. I myself have transplanted 3 patients, and it's not for ALPS, but it is for other issues. And one of the issues that is something that worries me about this patient is, as you raise in your questions, how long can you treat a patient like this with immunosuppressor therapy when you already started before the patient was 6 months of age? I don't believe in free lunch, so I think there's going to be a price to be paid. And in fact, one of the patients that I had to transplant was somebody who had been treated for more than a decade with combinations of therapy. And so the ALPS was burned out. That was the good news, but the bad news is that the patient had developed a combined immune deficiency at that point, just from chronic therapy. And this is in the pre-sirolimus days, when we used cyclosporin, Tacro, methotrexate, rituximab, steroids, all of these agents in some combination of many years. So that was really the reason why that patient had to be transplanted. And then another patient I've transplanted because she not only had a FAS mutation, she had also a mutation in an HOH gene, and she had these fevers and other things, and we couldn't make heads or tails of was it the ALPS that was causing this, or was it HOH that was causing this. So she actually ended up being transplanted before the age of 1 year. And then the third patient, and this is from the olden days of where patients with complex cytopenias would get their spleen removed at some point as part of the management. And we've learned that that's really a bad idea in ALPS patients. They have an increased risk of pneumococcal sepsis. And it's not just the removal of the spleen, it also has to do with certain types of memory B cells. So this patient would end up in the ICU 4 to 5 times a year with what looked like pneumococcal sepsis, although we couldn't always find pneumococcus, and that's because the patient was on preventative penicillin and IVIG. And then later on, when we did whole exome sequencing on the patient, we found that he also had a TRAPS mutation. So he had ALPS and he had a periodic fever syndrome. And so some of these episodes were likely related to the periodic fever syndrome. But to sort this all out, we ended up transplanting him as well. And I have to say that these transplants are very difficult. And I think that's one of the reasons why we don't do it. But let's go to the remaining questions, because I think this is really what we should be focusing on. And I added, for myself, another question is, what does the parents and other families look like? And that can be important because hypothetically speaking, let's say that the patient has a matched sibling with one of the mutations, but not the second one. Would you use that sibling as a donor? Well, the answer seems to be no. Why would you do that? But I think it's important to figure out how these particular mutations line up with FAS-mediated apoptosis and ALPS. Because if this is a truncation early on in the protein, I am wondering if this particular mutation is able to make protein. And if that's the case, then in the carriers, you could argue that the trimers are completely derived from the normal allele. In other words, only the normal allele contributes a normal FAS protein to the trimers. So that really makes me think, what would that FAS-mediated apoptosis look like in the carriers? It is typically missense mutations in the death domain that have the severest form of an apoptotic defect. Because remember, the protein is made, it's not a functional protein because it doesn't signal through the death domain to the FAS signaling pathway, but it becomes a part of the trimer. And that is why these mutations are so bad. If you have a more global defect in the protein, you have to see if that protein actually becomes part of the trimer or not. And that's one of the reasons why I think we should look at the parents and see what that looks like, including what their biomarkers look like and what their ALPS panel look like, if only for adequate genetic counseling. Do you need to transplant these patients? Do you need to? I think it's really a good question, and I'm really interested to follow these patients along to see what happens. My prediction is that you will not be able to get her off therapy, and the other question is, are you able to prevent lymphoma from happening, and are you able to prevent more widespread cytopenias from happening? And my answer is that as long as you are on sirolimus, you probably are able to prevent that from happening, but you're going to be running into immune deficiency problems at some point. You can even argue if she would be able to develop normal immune responses to vaccines and to natural infections. So I would be scared to see what happens if and when she gets EBV or CMV or something something like that. So I think what you do is you get ready, you go and look for donors and see what is available. And then you come up with a game plan. What do you do when the cytopenias get out of control? What do you need to do to regain remission? And then if and how are you going to transplant these patients? But from my own experience and what I've heard is patients with biallelic mutations don't survive unless you transplant them, with the caveat that a lot of these these reports are all from the pre-sirolimus age. So it might be that this is a different scenario with sirolimus. But I have the same question with my own patients who have just the typical run-of-the-mill standard form of ALPS, if there's such a thing as standard ALPS, is who do you start treatment on, and what kind of treatment goals should you think about? We can put them all on sirolimus and things will get better, but what are the goals and what are the expectations? And are you going to do this lifelong, or what are kind of the thoughts about stopping it? And then if there are no match options, that's why let's say that's why you want to know what the parents' studies look like. Let's say it's completely normal. I don't know, but in that case, you could potentially always go back to an haploidentical parent, or maybe the parents it is more than haploidentical, right? If there's already consanguinity regarding one thing, it might be that the parent is phenotypically matched to the child as well, or in the family. And as we see with many of these patients from the Middle East. So I think you want to know what you have in terms of donor availability. Yes, and then how to transplant. My experience in the patients that I've transplanted is that these were really tough transplants. They all developed graft versus host disease, all three of them. And I think it is probably not good to transplant when you have these amount of soluble fast ligand floating around, and then a normal immune system comes in with, for the first time, normal fast expression on cells. So you would have to really do some work in advance to get this disease process under control as much as you can. And I think it remains to be seen how well you will be able to do that with your therapy. So in other words, clinically you may be doing well, but your biomarkers may remain quite abnormal. And interrupt me.
I actually have a follow-up question. I don't know if it's going to echo for a minute, but in regarding to surveillance of biomarkers for her, aside from doing just flow cytometry to look at the double negative T cell population, is it good to kind of monitor all of her biomarkers, or specific ones that are more important to kind of monitor for her? I was trying to think about what's the best thing for like surveillance in that sense.
Well, it's tough. So we've seen in patients on sirolimus, and again, these are sort of your typical patients. We see basically normalization of the ALPS panel, and it's really the only drug that does that, in my experience. And you can get normal levels of your biomarkers as well. And I think that soluble fast ligand is probably the best one. And there's some studies published, right, that look at combinations of biomarkers in sort of the diagnosis of ALPS. You can make a diagnosis of ALPS without ever measuring double negative T cells, just by the fact that vitamin B12 is not elevated in a lot of scenarios, and certainly not in children. IL-10 as an isolated cytokine is really the only disorder that I know of, and then the soluble fast ligand. Those are probably good. You show that the soluble IL-2 receptor level is sky high, and I see the same thing even in patients that are completely asymptomatic. So it can be 20,000, 30,000, and 40,000, and the patient is just walking around without any clinical manifestations other than maybe a slightly enlarged spleen and some lymph nodes. So I think you're doing the right thing. I think it's the imaging that is important, and I think sirolimus is the drug that really changes the lymphadenopathy and the hepatosplenomegaly as well. And I had a really interesting, I have identical twins with ALPS, and it's really interesting because they don't have the same severity of disease. So the more severe twin, I started on sirolimus, years ago, and the other one had some symptoms but nothing major. I started on Cellcept. So there was an interesting experiment where we could follow them, and then we looked. A year later, we did some imaging, and we noticed that the patient on Cellcept really was doing very well, and biomarkers were better, but the imaging abnormalities were more or less unchanged. PET scan was relatively unchanged, but his twin brother on sirolimus really had, burned out imaging. The PET scan was much better. So to me, that really indicates that these two drugs are not the same in terms of what they can achieve. But it goes back to the question, in patients other than yours, do you need those patients? Do you need to start those patients immediately on therapy, and what kind of therapy do you start with? So that's why I'm always interested to see if your patient is a patient with just lymphoproliferative disease, or if your patient has autoimmune cytopenias as a presenting manifestation, or has developed cytopenias as part of the disease process. Because in my experience, that appears to signal a change in phenotype. Once you have developed autoimmune cytopenias, there's typically no way back to just the lymphoproliferative phenotype. And I think that's important, because if you have a 10-year-old patient and you have another 80 years to go, in the absence of clear curative treatment goals, I think that's something to consider in your patients with ALPS. This patients, I think it's a different issue. Other questions?
Yeah, this is Dr. Sawasham from Children's Hospital of Michigan in Detroit. First of all, very nice case presentation. I congratulate you, and really insightful input from Dr. Bleesing. I appreciate this. My question is, obviously you mentioned that we continue giving these patients immune suppression, and there's a really quite significant risk of development of Hodgkin lymphoma as well as NHL. So do you think that this immune suppression of this, long period is a contributor to the development of Hodgkin and non-Hodgkin lymphoma? That's my first question. And the second one is that, if I am remembering correctly, there is an increased incidence of Rosai-Dorfman disease in these patients, at least at the histology level. I remember talking to Dr. Jaffe several years ago, and I saw one of their publications, up to 37% of the lymph nodes they have reviewed as a second opinion. I had some histologic evidence of Rosai-Dorfman. So my second question is that, is there any biology to relationship between, ALPS and Rosai-Dorfman disease? Thank you.
So let's start with the second question, because I was just talking to Ashish Kumar not too long ago, because he had a new RDD patient, and that sort of made me go back to the literature, and it's old literature, right? It's we know everything that's older than 2 years we call old literature, but this is from many years ago, and it is from the NIH group, and there's not been a lot of sort of follow-up studies that we have looked at. So here's one of the problems, is that we have done such a good job in educating everybody about ALPS, is that we rarely do any lymph node biopsies anymore. In fact, this case is kind of unusual. If this case had been in my institution, we probably would have done just flow on peripheral blood, and we would have made the diagnosis, and we might not have made these patients undergo a lymph node biopsy, although in this case probably would have. So we don't get lymph node tissue anymore in these patients. So we don't really know if they're developing features of Rosai-Dorfman disease. It's possible, but it has a histiocyte component. And we don't really know much about fast and fast-mediated apoptosis in non-T cells or in myeloid cells. It probably plays a role in those cells as well. So maybe in histiocyte it plays a role as well. So we just don't know. The first question is, I think so. I think if we have patients on sirolimus, we probably preventing these patients from developing certain types of lymphoma. Although I'm worried, and that's what happened with my patient who was transplanted. He became chronically EBV positive, so we might be eliminating one form of lymphoma, and we might be increasing the risk of another form of lymphoma. In this case, of EBV-driven non-Hodgkin's, and that's typically not what has been described in ALPS patients. And then, if you talk to pathologists, because for a period of time, a lot of patients were sent to me who had this isolated finding of progressive transformation of germinal centers. And that's something that you see in certain forms of lymphoma as well. And then you see this in ALPS. So there was another interesting observation. So I think the jury is still out, but my sense is that you probably change the natural history of ALPS while you're on sirolimus. My experience is that after many years, and patients expressed a wish to be taken off sirolimus, even if it's done over time, and you stop this, they are at risk of relapse of their disease. So it doesn't change this permanently. It probably creates some honeymoon period where the patient is doing okay, but then their manifestations of ALPS come right back. And there has been a theoretical concern that it remains to be seen whether they respond to sirolimus in the same degree as they did when they were put on this medication in the first place. So so that's why I'm hesitant in starting my sort of typical ALPS patient who only has evidence of lymphoproliferative disease on these heavy gun immunosuppressive drugs, even though we know that it works really well in all aspects of ALPS manifestations, because it is really tough to decide how to take them off. Do you de-escalate them to CellCept, or do you take them off to nothing? I think those are all really studies that are begging to be done.
Hi, I'm Gila Spitzer. I'm the transplant physician at Hackensack. So we've typed the child, we've typed the parents, and interestingly, the child, as you may or may not expect for a consanguineous family, is homozygous. Is a homozygous typing. So both parents are hapless in the direction of rejection, but fully matched in the direction of GVHD. And she has a young aunt who has the same typing as the parents.
Right.
So she's got some good donor, and we didn't do any genetic testing or functional testing on the aunt or the parents yet, but that I think would be something I would do before deciding on a donor. So do you have any thoughts in that setting of potentially doing a more preemptive transplant when she's a little bit older? I probably wouldn't do it in a 1-year-old, but maybe in a 3 or 4-year-old, in someone who we foresee will have a need for transplant, in a well-matched donor. And you could consider the use of maybe PT-Cy, triple PT-Cy TAC-MMF in a patient like this, where you kind of have a haplo in the mix. And it's good GVHD prophylaxis. So if GVHD has been a concern, that would be pretty good, robust coverage in a fully matched GVHD setting.
Yep.
Do you have any thoughts about that?
So a lot of these patients, and we transplant. I'm one of the. I guess I'm the immunologist. I'm also the transplanter. So I know what's involved in transplanting these patients, and why I've been reluctant in transplanting other patients, even though I think we should always ask the question, is curative treatment possible? Because why would you condemn a patient to a lifelong experience with ALPS. In this patient, I'm not sure why you would wait for 3 or 4. Why not do it now? While you don't have acquired EBV, while you haven't acquired CMV, and have to worry about those things after transplant. We also know that we have better tools of T-cell depletion. And I think PC sort of post-transplant PSI may be an excellent way of doing this, particularly since it does such wonderful things for regulatory T cells in patients, and that might be really what they can need right after transplant when there is still a lot of things going on. I would probably use patients like this. I use cyclosporin, MMF, and I use abatacept. And I use abatacept for a very long time, just following kind of the literature that comes out of adults, with hemoglobinopathies and leukemias. And then one of my patients probably didn't do very well because of TMA, and that's probably another complication of this immune dysregulatory phenotype of these patients. So there are quite a few things that you can do to monitor for that and to intervene if possible. If the aunt, so I think you really want to know if the aunt has a FAS mutation. If she doesn't have a FAS mutation, I think you are in luck. And I probably would use her because you have her around. You can make, you can go back and do, T-cell therapy if you have to. You can have, you have her around if you need to deal with, a rejection setting. So that would probably be my approach. One of the problems is that there is homozygosity. So there's probably homozygosity for other things as well that you don't know about, but that may have implications for the transplant setting. Well, as I mentioned, TMA and other things. So sometimes getting an unrelated, a matched unrelated donor, you don't have to worry about either FAS or some of these other areas of homozygosity.
Yeah, I think she has maybe one MUD on prelim search, I think a 32-year-old, if I remember correctly. So, and maybe some 9 of 10. So,
yeah,
so not great.
But I think you are. It's interesting, right?
Homozygous, yeah.
So you have something in the graft rejection that you may not have in the GVH direction, or vice versa, that can work in your advantage.
Yeah, yeah.
So, and since you have the aunt, under your nose, so to speak, you can probably manage the rejection direction while you have less things to worry about in the GVH.
Right. Yeah, no, I think that that would be my plan, assuming that the aunt is not a carrier as well. And there's actually that, this aunt is 16, 17. So there's even another generation of fairly young great aunts and uncles that we could type, who may also kind of be matched, and they wouldn't be that old either in terms of looking for donors.
Yeah, so I think there's a sweet spot in terms of timing, right? I think there is probably increased improvement as long as you keep her on immunosuppressive drugs, but then I think at some point there is sort of diminishing return on an investment, and I think that's a difficult time to predict. But if you're ready to go, then you know that if there's something else happening or these patients develop, infections, then I think that would be sort of the time to get going.
Yeah, I think the question is, in absence of other triggers, at what age or length of sirolimus therapy do you say, now's the time? In some other settings, and like, some other CIDs, maybe you can kind of wait until they're a little bit older, have a little bit more kind of development under their belt.
So I think so. I think there is certainly, I think there is some maturity in terms of handling some of the conditioning drugs that you are maybe thinking of, but I think you're beyond that now at 1 year of age. And then I think it is, I don't really see, you know, how easy it is to transplant a 1-year-old versus, you know, a 10-year-old. So a 2 or 3-year-old probably doesn't matter either, but I'm not sure what else benefit there is in waiting too much longer. I think I understand it. It's a difficult issue, but I think in this case, from what we know in the literature, I'm hard to see that this is something that can be managed without a transplant. And then it's really, do we see that the organomegaly and things have improved? Do we see that biomarkers are at their lowest levels? And then maybe it's time to go, and maybe you continue the sirolimus as your GVH agent. You might, there's different ways of doing this. But I found these very difficult, and that's why I haven't been transplanting, you know, these patients, because it was really a frustrating experience. This is all before we recognized TMA as a problem, before we had, you know, abatacept, or even before we had, you know, post-transplant cyclophosphamide. And I think all those new developments, I think, are changing the landscape of ALPS transplant, and I think it invites the community to think about, you know, who needs to be transplanted beyond sort of the severe case that, you know, is presented today.
There's a couple of questions or actually a question in the chat and a comment. And I think one of them you already addressed, Dr. Bleesing, but so the question is, from a theoretical perspective, is there a role for giving sirolimus in the post-transplant GVHD prophylaxis setting? Would that ameliorate the inflammatory milieu, affect the effective function?
Maybe. Just remember, right, that as the BMT community says, once you are in a BMT unit, you cease to be an ALPS patient and you become a BMT patient. But in this case, that might be a good option. It's also, you know, nicer for kidneys in contrast to cyclosporin and tacro. It probably is less TMA causing, although we see lots of TMA in immune deficiency patients, and we see lots of TMA in patients from the Middle East as well. So that would certainly something that I would be monitoring for. And if this patient was in my institution, I probably would have this patient on preemptive, you know, Solaris after transplant as well. But that's a little bit, you know, sort of the Cincinnati approach to BMT. But that might be a good option to use that as your GVH drug. But I would add abatacept as well. You know, sort of the standards -1, +5, +14, and +28, and then you can continue based on how well the patient is doing.
When you mentioned TMA,
sorry, can I follow up on the abatacept for 1 second? Shipra, I'm sorry to interrupt.
No worries.
Would you use abatacept on top of PTSI, or you would choose one or the other?
Well, probably one or the other.
Okay.
We have certainly in older patients, we see a trade-off with, you know, viral reactivations. But that again, you have a young patient. This patient may be completely naive in terms of EBV and CMV status, so it is something to consider. I think abatacept has been really a great addition in our immune deficiency transplants in patients who were on fire before we moved to transplant, and HOH patients sort of fall in that category as well.
I guess just my question about the TMA that you see more, you said in the Middle Eastern patients, do we think that's something genetic as well? And
yeah, it probably is. And we see it in African Americans, right? And it has to do with the meningitis belt in Africa. So it probably provided a genetic survival advantage to be really good and to quickly activate your complement system. It's probably not as good in sort of acquired situations such as BMT. So we see this certainly in our African American population and in our Middle East population as well. We have good biomarkers to look for it. So, you know, you're not sort of, you know, wandering in the darkness. You can look at it and you can act accordingly.
That's very interesting. I mean, one wonders with COVID and MIS-C that we saw in kids. I think there was also skewing towards the African American population. So that's interesting that
Yep.
they're more inflammatory. Just one other last comment. I know we're running out of time, and thank you so much, both of you, for a wonderful presentation. So another thing that was raised was, could any cousins be a 10 out of 10 match for this patient? Holly Miller says she had a recent consanguineous family whose cousin was identified to be a 10 out of 10 match. Would it be good to type more extended family members?
We do in our patients from the Middle East for sure, particularly when we see homozygosity in HOA types. Yes, we can find them all up and down the family tree. And then we could look at secondary things like not having the gene that you're worried about. You can look at ABO matching, and ABO matching can be important and helps as well, particularly if you already have Coombs positive anemia. If you have the luxury to also match an ABO type, that can pay off after transplant as well, and then you can match for viral exposure. So yeah, it's we do it. We sometimes have extended typing of family members to look for the best possible matched 10 out of 10 matched donor.
I know we're running short of time. I think Adrian had his hand raised. Maybe quickly we could
I
answer.
know we're running out of time, and I also don't want to take over the discussion on this very interesting and complicated case. I think we initially wanted to present my patient as well, who has very mild kind of presentation. I think Jack Bleesing, Dr. Bleesing, I think my colleague John McDonald also already mentioned about this patient that has very mild ALPS presentation because of the fast mutations, and on top of that has IBD as well. I just do not know whether IBD is something that we see with ALPS, or is it completely red herring?
You can get autoimmunity in other tissues, right? There's been the first sort of the poster child of the NIH group developed, fulminant liver failure because of autoimmune hepatitis. So there are probably familial defined risk factors that set you up for certain other autoimmune features. It can be the kidneys, it can be other things. So yes, I have to say we're doing so much genetic testing these days that now I'm seeing patients who have an abnormal variant or mutation in FAS, and we're trying to work our way sort of backwards to determine if this is actually an ALPS patient. And what I've tried to teach, our old fellow, Dr. McDonald, is that even if you have an abnormal FAS-mediated apoptosis, that doesn't prove that you have ALPS. We know that in family members. So you really want to look at other diagnostic features of ALPS that Melanie showed in her presentation, and you want to look at the clinical presentation to see if they in fact have ALPS. So that is something new that we're starting at the genetic level, and now we're working our way backwards to the clinical.
Backward reverse.
This is the theme of immunology, right? And it is keeping my diagnostic lab in operation because we're getting so many variants of uncertain significance that you need some biological correlate to figure out what this means. And certainly for VAS variants, we can do that by our apoptosis study, which is, by the way, not an easy assay to do. It's a functional assay. These are tough to do. The presence of double negative T cells, that probably is the closest correlate to the apoptosis feature of ALPS that we know of. And then the rest of our ALPS panel, focuses on other parts of the ALPS pathogenesis.
And just one last quick comment, if you can comment, if this patient now has IBD and could be part of the ALPS, is on infliximab right now, should we switch to sirolimus? I guess that's the question. He's doing well on infliximab.
I don't know what your pathology looks like, but if your pathology looks like, slam dunk IBD, then I think you probably need to stay on an IBD treatment path and just determine if your treatment has success or not. And let's say this patient develops kind of ALPS features, then it would be an interesting question if you can kill two birds with one stone.
Thank you so much.
Thank you so much, both of you. Thank you, Dr. Bleesing, for joining and giving us your expertise on this topic. Fascinating case, Melanie. I hope this patient does well. And thank you to everyone who participated in this webinar. Thank you. Take care.
Yep, take care.